So there is this very specific type of pain that can, well, it can either be cured with a simple bag of frozen peas or, a scalpel.
Right.
And the really terrifying part, you take an X-ray of the patient's leg. Both of those scenarios look entirely perfectly identical.
Perfectly normal X-rays.
Exactly. So picture this. You're sitting in clinic and you have a 20-year-old runner.
Yes.
A 20-year-old runner sitting right there on the exam table in front of you.
Okay, a runner.
And they're complaining of anterior shin pain. But it is not just a random generalized ache. It comes on at the exact same distance during every single run.
Like clockwork.
Let's say it hits at 2 miles.
Right.
Right, 2 miles, like absolute clockwork. And then once they finally stop running, the pain settles down completely within 15 minutes.
15 minutes of rest.
Yep, 15 minutes of rest, and they tell you they feel totally normal again.
So as the clinician, I mean, your first instinct is to get a radiograph, right? An X-ray of that tibia, just to see what the bone is actually doing.
Right, and it comes back completely normal, just pristine. And the physical examination, you examine them in the clinic, between their runs, and again, you find absolutely nothing.
No tenderness, no swelling at all.
Nothing. But here is the kicker, right? This 20-year-old runner has already been told twice by 2 completely different professionals at other clinics that it's just shin splints.
Told twice that it's shin splints. Well, I mean, it absolutely might be shin splints. We see that constantly, But it might also be a true stress fracture of the tibia.
Right.
Or, and this is the terrifying part, it could be chronic exertional compartment syndrome. So we are looking at 3 potential diagnoses here, all sharing that exact same symptom profile, but presenting with completely different, completely non-overlapping treatments.
Which is where my bag of peas and scalpel analogy comes in.
Precisely. Because one of those diagnoses just requires you to prescribe simple rest and ice. Another requires you to immediately put the patient on crutches and order an advanced scan because the bone is literally failing. The third one requires a knife. It requires a surgical fasciotomy.
Man, I am just sitting here thinking about the liability of that. I mean, how do you actually separate them? How do you look at a young, healthy athlete with a perfectly normal X-ray and figure out if they need ice, crutches, or a scalpel?
You do it with exactly 3 pressure numbers and 1 specific bone scan pattern. That is the fundamental key to this entire deep dive today.
Awesome.
This is the finale of our lower limb modules. We are running the ultimate masterclass for the young athlete with a normal X-ray. We are mapping out the entire lower limb today. So the groin, the hip, the shin, the hamstring, and the Achilles tendon.
Basically, the demographic of patients who are just, well, way too young to be in our joint replacement modules.
Too young for a hip or knee replacement today? Yes. But they are the exact patients who will end up absolutely needing a major joint replacement in 20 years.
20 years.
Yes. In 20 years, if you get these biomechanical diagnoses wrong right now, the stakes are just incredibly high. If you fail to understand the geometry of their injury today, you condemn their joints to catastrophic wear and tear tomorrow.
Wow. Okay, let me feel the pressure now. Let's start at the very top of the kinetic chain. The groin.
Let's do it.
Looking at the exam bank, there are 5 questions on this. 5 questions on this one condition alone, which tells me the examiners consider it extremely high yield, athletic pubalgia.
Very high yield.
So for everyone listening, I want to try and logic this out. If we are talking about groin pain in an athlete, where is the primary site of injury?
What's your instinct?
My immediate thought goes to the adductor longus origin because, that's what gets strained when someone does the splits. Or maybe the conjoint tendon or the inguinal ligament.
And that right there is exactly why they test it. You are falling into the classic examiner's trap. It is none of those. Really. The primary site of injury in athletic pubalgia is the rectus abdominis insertion. The rectus abdominis insertion onto the pubis.
Wait, the rectus abdominis. We are talking about the lower abs.
We are. Exactly where the abdominal muscles attach to the pelvic bone.
I'm really struggling with that. Why the abs? The patient comes in complaining of groin pain. There is a specific question here about the mechanism of this injury. I mean, how does a groin problem start in the stomach?
The mechanism is highly specific, and it explains the anatomy perfectly. It is repetitive trunk hyperextension and thigh hyperabduction.
Repetitive trunk hyperextension and thigh hyperabduction. Got it.
Yes. And before we break down the physics of those 2 movements, I need to give you a demographic absolute for your exams. This condition occurs almost exclusively in male athletes.
Almost exclusively in male athletes. Okay.
Exactly.
So male athletes, trunk hyperextension and thigh hyperabduction. I want to visualize this because reading it on a flashcard feels like reading a physics textbook.
Yeah.
Why that specific combination of movements?
Think about the pelvis as a fulcrum. That specific combination of movements creates a literal tug of war across the pubic symphysis. Picture a soccer player.
Okay, the soccer player.
He is running at full speed, and he stretches backward for a ball in midair. His trunk arches completely backward. That is your severe trunk hyperextension. This pulls the rectus abdominis violently upwards, northward.
So the abs are basically trying to rip the top of the pelvis up toward the ribs.
Exactly. But at the exact same fraction of a second, his leg is reaching way out to the side to intercept the ball. That is the thigh hyperabduction. This movement fires the massive adductor muscles of the thigh, which pull violently downwards, southwards on the exact same pubic bone.
Oh, wow. So the pubic symphysis is just the rope caught in the middle of this tug of war. The abs are pulling north, the adductors are pulling south with like hundreds of pounds of force.
And the rectus insertion loses. Every time. It is the weakest link in that fascial chain. The tissue microscopically tears at that upper insertion point.
Which brings us to the clinical findings when this athlete eventually limps into the clinic. If the upper insertion is what tears, they must have severe abdominal pain when you push on it, right?
You would definitely think so, but here is the commonest physical finding, and it comes with a very specific percentage you must memorize. The most frequent finding is pain with resisted hip adduction, occurring in 88% of patients.
Wait, 80%?
88%.
Hold on, I need to say this back because it feels like a massive paradox. 88%. Exactly 88% of patients have pain on resisted hip adduction. But the injury we just established is on the abdominal side. Why on earth is the pain down in the thigh adductors?
That paradox is exactly why it is the highest yield fact in this entire segment. You are testing the adductor side of the tug-of-war, but the structural failure is on the abdominal side.
Okay, but why does it hurt down there?
Because they share a fascial envelope over the pubis. When you ask the patient to squeeze their legs together against your resistance, you are firing the adductors. Those adductors pull down on the pubic bone, which tilts the bone and physically stretches the torn, inflamed rectus insertion up above. The adductor isn't torn, it's just pulling the fire alarm on the abdominal tear.
That is wild. That completely changes how I view this exam.
Yeah.
You are using an intact muscle to tug on a damaged tendon from across a joint.
Precisely.
What else are we looking for on the physical exam to confirm this?
Well, in descending order of frequency, you will find parapubic tenderness, meaning pain, when you press directly on the bone itself in about 25% of patients.
25%.
Right. You might find adductor longus origin tenderness in less than 33%.
Less than 33%.
Exactly. And pain with resisted sit-ups firing the abs directly is actually present in less than 50%.
Less than 50%.
Yep. But here is the most crucial definition of all. There is no hernia. By definition, there is absolutely no hernia.
So if I am examining this patient standing there in the clinic and I feel a palpable bulge, like a literal hernia in the groin.
If you feel a palpable bulge, you are looking at an entirely different diagnosis. You are likely dealing with a true inguinal hernia, where the bowel is pushing through a defect in the abdominal wall. This is exactly why the old historical name for athletic pubalgia, which was sports hernia, is so notoriously terrible.
Oh, I see.
It caused decades of surgical confusion. There is no sac. There is no bowel. The abdominal wall has not herniated at all. The tendon insertion has simply failed from sheer force.
Okay, the mechanics are locked in. Let's logic out the management. If I have a soccer player with a 2-month history of this sheer force injury, my first instinct is that you just have to call a ceasefire on the tug-of-war.
Exactly.
You need to stop the forces pulling the bone apart. So I assume it's rest. But what comes after the inflammation dies down? I mean, we can't just rest them forever.
You are exactly right. It is rest, followed by a core trunk stabilization program.
Rest followed by a core trunk stabilization program.
Yes. The initial rest calms the acute insertional inflammation. But if they just rest and go back to playing, it will tear again on the very first kick. So you follow up with targeted core stabilization to strengthen the obliques, the transversus abdominis, and the pelvic floor. You are literally rebalancing the forces across the pelvis so the adductors don't overpower the rectus again.
But what if that conservative management fails? What if 6 months of core rehab just does nothing? I am looking at the surgical options, and one of them says modified Bassini repair. But wait, Bassini is a classic hernia repair.
Right.
You just told me 10 minutes ago there's absolutely no hernia. Why are we doing a hernia repair for a non-hernia?
It is a brilliant question. You are not repairing a hernia sac. You are borrowing a hernia surgical technique to artificially tighten the posterior wall of the inguinal canal.
Oh, I see.
The modified Bassini repair takes the transversalis fascia and the internal oblique muscle and sutures them down to the inguinal ligament. What you are doing is surgically restoring tension to the abdominal side of the pubic bone, essentially giving the rectus insertion structural backup so it can actually win the tug of war.
That is fascinating. You are basically building a reinforcing wall behind the failing tendon.
Exactly.
But there's another surgical question here, one about an adductor tenotomy. And this one seems wild to me. The source text asks about the outcome of surgically releasing the adductor tendon for chronic pain. If I literally cut a professional athlete's adductor tendon, wouldn't their leg be permanently weak? Wouldn't their career be over?
It is highly counterintuitive. The answer is that they return to full sports participation, despite objectively decreased adduction strength. The specific data point you need is that 12 out of 16 patients, 12 out of 16, return to full sports participation at a mean of 14 weeks.
14 weeks.
Yes, 14 weeks. And they did so despite measurably, objectively decreased adduction strength on a dynamometer.
I really have to wrap my head around this. You physically sever the tendon. The adduction strength drops. But functionally, they just go back to playing professional sports. How does the leg not just fly out to the side?
Because the adductor longus is not the only adductor. The magnus, the brevis, the pectineus, they all compensate. The absolute peak strength doesn't come back, but functionally, for the mechanics of running and kicking, it just does not matter. The pain relief from stopping the tug of war outweighs the mild loss of peak torque.
That makes sense.
And this is highly useful when you are sitting across from a terrified athlete. You can look them in the eye and say, yes, a machine will show you are slightly weaker, but you will be back on the pitch at full capacity in exactly 14 weeks.
Wow. I can definitely see how candidates get destroyed by this topic. Let's explicitly lay out the trap.
The trap across all 5 of these exam questions is looking for a palpable hernia or looking for a pure adductor muscle tear. Candidates consistently reach for the inguinal canal or the adductor longus origin as the primary pathology.
Because those are the things general surgery rotations drill into you to feel with your hands.
Exactly. They're tangible. But you have to remember the disconnect. The structural injury is at the rectus insertion, the pain presents predominantly on the adductor side, and there is absolutely no hernia whatsoever. 3 separate anatomical concepts inextricably linked into one condition.
Okay, give me the one-liner for athletic pubalgia to close this out.
Athletic pubalgia is a rectus abdominis insertional injury in a male athlete resulting from trunk hyperextension and thigh hyperabduction, presenting with pain on resisted adduction in 88% of cases and absolutely no hernia.
Got it. Let's transition laterally. If a patient is limping from groin pain, altering their gait for months, they naturally start shifting unnatural mechanical loads onto the actual ball and socket joint. Let's talk about the hip, segment 2. The femoral neck stress fracture. You call this the one you must not miss.
You absolutely cannot miss it because the penalty for missing it is a vascular necrosis of the hip in a very young person.
Okay, let's set the scenario. You have a 22-year-old female military recruit.
A 22-year-old female.
Right. And she has 4 weeks of insidious hip and groin pain. 4 weeks. Exactly 4 weeks of pain that gets progressively worse with marching. We get an MRI. The MRI shows an inferomedial stress fracture of the femoral neck. So the crack is on the inferomedial side, and there is 0 displacement.
The location is the entire game here. It is on the inferomedial side. That means it is on the compression side. Understanding the physics of why that matters dictates every single treatment decision you make.
So explain the physics. Why does the side of the bone matter if a fracture is just a fracture?
Think of the femoral neck as a cantilever bridge projecting out from the side of a cliff, okay?
Okay, a bridge.
The shaft of your femur is the cliff face. The neck sticks out horizontally to hold up the ball of the hip joint, which carries the weight of your entire torso. When you stand, your body weight pushes down on the ball, while the ground reaction force pushes up through the shaft.
So the neck of the femur is constantly being bent downward.
Exactly. It is experiencing bending momentum. This bending creates 2 completely opposing forces on the bone. The superolateral side, the top part of the neck, is being stretched apart as it bends downwards. It is under tension. But the inferomedial side, the underside of the neck, is being squeezed together by that same bending motion. It is under compression.
Okay, I see it. So if you have a hairline crack on the top, the tension side, every time this 22-year-old takes a step, the bending force is literally prying that crack open further.
Precisely. Tension propagates the fracture. It literally wants to rip the crack completely across the bone. That is why tension side fractures are surgical emergencies. If they complete, the neck snaps, the blood vessels to the femoral head tear, and the bone dies. But on the inframedial side, the compression side, every single step you take squeezes the crack firmly closed. Compression compresses.
Which means a compression side fracture is inherently more stable even if the patient is walking on it. That leads us right into the decision tree. I need to say this back systematically because there is a very strict numerical threshold here, isn't there?
Yes, there is. The entire treatment algorithm hinges on the 50% mark, 50% of the bone diameter.
Okay, saying it back. Branch 1. If the MRI shows the fracture is on the compression side and it is incomplete, meaning the crack crosses less than 50%, exactly less than 50% of the neck diameter, that patient gets protected weight bearing and observation. No surgery.
Correct. Less than 50% on the compression side is managed with protected weight bearing on crutches.
Branch 2. If the fracture is on the compression side, but the crack extends to greater than 50% of the neck diameter, then we intervene surgically with percutaneous screw fixation.
Yes. Greater than 50% means the structural integrity of the cylinder is too compromised, even in compression. You place percutaneous screws across the neck to act as internal rebar. 50% is the absolute threshold.
And branch 3. If the fracture is on the tension side, the superlateral side, or if it is a complete fracture anywhere on the neck, that is always surgical fixation.
Okay.
Always.
Always. Tension side is always fixed. No exceptions, no observation, period. Because tension propagates, as we discussed. If you let them walk on a tension side crack, it will pull apart. Tension propagates. Compression compresses. That mechanical principle applies to stress fractures everywhere in the human skeleton.
Okay, the 50% rule makes perfect mechanical sense. But I noticed a phrase in the conservative management pathway that feels like it's hiding a massive amount of clinical work. For the less than 50% compression fracture, the textbook says protected weight bearing and further workup. What does further workup actually mean? Aren't we just waiting for osteoblasts to fill in the crack?
If you just give her crutches and wait for the osteoblast, you are committing malpractice by omission.
Really?
Yes. When a 22-year-old woman developed a stress fracture in the strongest bone in her body, you do not just treat the bone, you have to ask why her skeletal architecture failed under normal military marching loads. This is a massive red flag. She needs a comprehensive metabolic assessment. This leads directly into the female athlete triad.
Ah, right. So if we have a young female athlete presenting with this femoral neck fracture, what specific clinical finding in her history would most support this underlying metabolic diagnosis? And how do we ultimately manage it?
The primary historical finding you are interrogating her for is amenorrhoea, the prolonged absence of menstruation. And the ultimate treatment, alongside aggressive nutritional correction, often involves hormone replacement therapy.
Let's unpack the triad for the listener, because I don't think people realize how devastating this cascade actually is.
The female athlete triad is a pathological cascade consisting of 3 interlinked conditions: disordered eating, amenorrhoea, and low bone mineral density. It almost always begins with disordered eating or simply a massive unintentional energy deficit. The recruit is burning 4,000 calories marching but only eating 2,000.
Right. Massive deficit.
The body is incredibly smart. It reacts to this starvation state by shutting down non-essential survival functions. The reproductive system is the first to go, leading to hypothalamic amenorrhoea.
And without the regular menstrual cycle, her estrogen levels just plummet. But why does the orthopedic surgeon care about estrogen?
Because estrogen is the ultimate protector of female bone. Bone is constantly remodeling. Osteoclasts break it down, and osteoblasts build it up. Estrogen normally induces apoptosis, cell death, in osteoclasts, keeping their bone-eating activity in check. When estrogen drops to postmenopausal levels in a 22-year-old, the osteoclasts just run wild. Bone resorption massively outpaces bone formation, leading to plummeting bone mineral density.
So the trabecular architecture inside the femoral neck literally thins out and becomes brittle.
Exactly. And here's the crucial clinical takeaway that examiners want to hear you say. The femoral neck stress fracture is just a symptom of the triad. It is not an isolated orthopedic event.
So fixing the bone of the titanium screw is actually the easy part.
Placing a screw under fluoroscopy takes 20 minutes. It is mechanically simple. But if you fix the bone and discharge her without addressing the energy deficit and the hormonal collapse, she will be back in your clinic in 6 months with a stress fracture in her tibia or her pelvis. It requires a massive multidisciplinary team. You need a sports physician, a registered dietitian to restore caloric balance, a clinical psychologist, and a gynecologist to manage the hormone replacement therapy.
That is a phenomenal breakdown. Give me the one-liner to wrap up the femoral neck.
A compression side stress fracture under 50% is protected weight bearing, over 50% requires percutaneous screws, and the tension side is always surgically fixed. And never forget, in a young woman, the fracture is merely a symptom of the triad.
Okay, let's do a rapid recap of the groin and hip to lock this into the listener's memory before we move down the leg. Recap 1. Athletic pubalgia. The primary injury is at the rectus abdominis insertion. The mechanism is a tug-of-war from trunk hyperextension with thigh hyperabduction, found almost exclusively in male athletes. The clinical paradox is that 88% have pain on resisted hip adduction. Paratubic tenderness is around 25%.
25%.
And by definition, there is absolutely no hernia. The initial treatment is rest, then core stabilization, modifying with a Bassini repair if that fails. If you perform an adductor tenotomy, 12 of 16.
12 of 16.
Return to full sport at 14 weeks.
14 weeks.
Despite an objective reduction in strength.
Spot on. And the femoral neck summary?
A compression side fracture under 50%. Exactly 50% means protected weight bearing and a massive metabolic workup. Over 50% means percutaneous screws. Tension side or complete fractures mean mandatory surgical fixation. And in a young woman, you always interrogate for the triad: disordered eating, amenorrhoea, and low bone density.
Perfect. We are moving down the kinetic chain to segment 3, the shin. This takes us right back to our cold open. We have a runner with debilitating anterior shin pain at exactly 2 miles, a normal x-ray, and 3 competing diagnoses. We need to separate medial tibial stress syndrome, stress fracture, and compartment syndrome. Let's look at the bone scan physics first.
Okay, let's say we suspect medial tibial stress syndrome, which the general public just calls Shin splints. What exactly does a technetium 99 bone scan look like if it's MTSS? I know the multiple choice options usually try to trick you with the timing phases of the scan and the visual shape of the tracer uptake. Is it focal or non-focal? Early or delayed phase?
The diagnostic answer for medial tibial stress syndrome is delayed phase uptake only, non-focal, along the posteromedial tibial border. Delayed phase only, non-focal, along the posteromedial border of the tibia.
I need to say this back in pieces and understand the physics of the scan. So saying it back, first, it is delayed phase only. That means when they inject the radioactive tracer into the blood, the shin doesn't light up immediately during the blood flow phase. It only lights up hours later when the tracer settles into the bone metabolism. Second, it is non-focal. It's diffuse, looking like a smear or a long linear streak down the bone, not a single bright hot spot. And third, it is anatomically located on the posteromedial border of the shin.
Exactly. Delayed diffuse posteromedial. That smear of tracer represents a broad area of periosteal inflammation where the muscles are pulling on the bone lining. Now contrast that underlying physiology with the bone scan of a true tibial stress fracture.
Boy, if a stress fracture is an actual crack in the cortex, there must be a huge amount of localized blood flow rushing to repair it, right? So if MTSS is delayed and diffuse, a stress fracture must be.
A stress fracture shows intense radiotracer uptake in the early phase, the blood pool phase, as well as the delayed phase. And crucially, it is highly focal. It is a brilliant localized point of intense uptake on the scan, like a laser pointer on the bone. So your discriminator on the exam and in the clinic is a 2-part physiological question. Which phase is lighting up? And is the uptake a smear or a dot?
So delayed and diffuse means stress syndrome. Early and focal means fracture.
Delayed and diffuse equals syndrome, early and focal equals fracture. That is the single most efficient heuristic in this entire module for telling those 2 distinct pathologies apart.
What about treating MTSS once we confirm that delayed, diffuse pattern?
It is almost entirely a conservative ladder. Activity modification, icing, and nonsteroidal anti-inflammatories. You forcibly reduce the mechanical load until the tibia adapts and remodels, but there's a very specific note in the source material about surgery that you must memorize. Surgical treatment, which involves the release of the soleus fascia along the posteromedial border of the tibia, is rarely indicated. Rarely indicated.
What does that release actually entail? Are you just cutting the muscle away from the bone?
Essentially, yes. You strip the deep fascial attachments of the soleus muscle off the posteromedial ridge of the tibia to stop it from pulling on the periosteum. But it is rarely indicated because most of these athletes get better with proper load management. The patients who don't recover usually have a missed underlying biomechanical cause like severe foot overpronation or massive core weakness that nobody has properly evaluated. Cutting the fascia doesn't fix a terrible running gait.
All right, that's 2 of the 3 diagnoses from the cold open. Now for the third, and this is where it gets highly numeric and incredibly painful. Chronic exertional compartment syndrome, or CECS. I demand the pressure numbers. The listener needs these tattooed on the inside of their eyelids.
You will definitively be tested on these 3 pressure thresholds. To diagnose CECS, we measure the hydrostatic pressure inside the fascial compartments of the lower leg using a large needle and a digital manometer. We measure it at rest, and then we put the patient on a treadmill until they are in agony and measure it again. Here are the pathological numbers. Resting pressure is greater than or equal to 15 millimeters of mercury. 15 millimeters of mercury at rest.
Okay, 15.
1 minute after stopping exercise, it's greater than or equal to 30 millimeters of mercury. 30 millimeters of mercury at 1 minute. And 2 minutes after stopping exercise, it's greater than or equal to 20 millimeters of mercury. 20 millimeters of mercury at 2 minutes.
I am repeating these out loud. 15 at rest. 15. 30 at 1 minute post-exercise. 30. 20 at 2 minutes post-exercise. 20. 15, 30, 20.
15, 30, 20. Rest, 1 minute, 2 minutes. I want you to visualize the visual shape of this pressure curve because the numbers tell a story of vascular failure. The pressure spikes dramatically during exercise, which is somewhat normal, but then it falls abnormally, agonizingly slowly. That is why the 2 minute number 20 is lower than the 1 minute number 30, but it is still pathologically high.
Right, because I am trying to imagine the physiology here. In a normal, healthy leg, that pressure would have crashed back down to a baseline of like 5 immediately once they stepped off the treadmill, right?
Exactly. The 4 fascial compartments of the lower leg are essentially tight, inelastic leather sleeves holding the muscles. When muscles work hard, they engorge with arterial blood and swell by up to 20%. In a normal leg, the leather sleeve stretches just enough, and when you stop running, the venous blood pumps out and the pressure drops instantly. But in CECS, the fascia is too tight. It does not yield. As the muscle swells, the pressure skyrockets, physically pinching off the thin-walled venous outflow tracts. The arterial blood keeps pumping in, but the venous blood can't escape.
Wow, it's essentially a self-strangulation of the muscle.
It is a temporary exercise-induced ischemia. The abnormal compartment is still choked with blood and elevated at 20 millimeters of mercury at 2 minutes. The delay in the pressure falling is the entire pathophysiology of the disease.
That sounds absolutely excruciating, like a blood pressure cuff inflated inside your calf. What else is on the differential diagnosis list for this specific kind of ischemic leg pain?
You have to consider a tibial stress fracture, popliteal artery entrapment syndrome, which also causes exercise-induced ischemia, but stems from a main artery being kinked behind the knee, medial tibial stress syndrome, and various nerve entrapments. But here is the explicit exam point they want to trick you with. A femoral neck stress fracture is not in the differential for CECS.
Well, obviously not. The femoral neck is up in the hip, and we are talking about compartment pressures in the shin. It's literally the wrong anatomical half of the leg.
It is the wrong part of the leg. But under intense exam time pressure, fatigued candidates see the word stress fracture in the multiple choice list and blindly click it. Do not fall for it.
Okay, now we need to talk about actually treating CECS, because reading the source text, there seems to be a massive contradiction, like a clinical dilemma.
There is an errata, a philosophical conflict in the source material that you need to navigate carefully. One question simply asks for the recommended treatment for CECS. The provided answer key says activity modification. But if you read the detailed explanation text below it, it flat out states that non-operative management is overwhelmingly unsuccessful unless the patient is willing to completely avoid the offending activity, and that the definitive surgical management is a fasciotomy of the affected compartments.
So if I am sitting in the exam hall or I have a desperate patient asking what to do, which one is the right answer?
You have to read the exact wording of the question stem with extreme care, because both answers are clinically defensible depending on the phrasing. Here is the honest, real-world reality. Activity modification is the only effective non-operative option. Physical therapy, stretching, and ice do absolutely nothing to change the inelasticity of human fascia. But activity modification only works if the athlete actually stops running entirely.
And let's be real, you're telling a 20-year-old marathon runner to take up swimming instead. They aren't going to stop.
They rarely stop. which is why a surgical fasciotomy, making long incisions down the leg to surgically slice open the tight fascial compartments, giving the engorged muscle room to physically expand out of the casing, is the definitive treatment, because athletes will not stop the offending activity. If an exam question offers both options and asks for the recommended or initial treatment, you answer activity modification. If it asks for the definitive or surgical treatment, you answer fasciotomy of the affected compartments.
That is a crucial semantic distinction. Let's wrap up the Shin with a definitive one-liner.
Delayed and diffuse uptake on a bone scan is medial tibial stress syndrome. Early and focal uptake is a stress fracture. And chronic exertional compartment syndrome is defined by fascial pressures of 15 at rest, 30 at 1 minute, and 20 at 2 minutes, treated initially by stopping the activity or definitively by a surgical fasciotomy.
Fantastic. Moving down the limb to segment 4, the lateral knee and the iliotibial band, or ITB. We have a new scenario. A 28-year-old runner.
28-year-old.
Presenting with sharp, stabbing pain over the outside of their knee, specifically at the lateral femoral epicondyle.
This is the classic textbook presentation of iliotibial band friction syndrome. And diagnosing this biomechanical failure comes down to one magic number. The pain peaks and is worst at exactly 30 degrees of knee flexion. 30 degrees.
My question is, why 30 degrees? If it's a tight band, why doesn't it hurt most when the leg is completely straight and stretched, or when it is deeply bent in a squat?
Because of the precise geometric mechanics of friction. The iliotibial band is a massive, thick, fibrous continuation of the fascia lata that runs all the way down the outside of the thigh and attaches just below the knee at Gerdy's tubercle. As you dynamically bend and straighten your knee during the gait cycle, this incredibly tight band slides back and forth across the bony prominence on the side of your femur, the lateral femoral epicondyle. From 0 to roughly 29 degrees, the band sits entirely anterior, in front of the epicondyle.
Okay, I am visualizing it sitting in front of the bone.
Now, at exactly 30 degrees of flexion, the tension vector changes. The IT band physically shifts from being anterior to the epicondyle to being posterior to it. That 30-degree mark is the exact geometric moment the thick band violently snaps across the bony peak. It creates maximum shear friction on the bursa lying underneath it.
That is horrifying to picture. So every single stride a runner takes, 1,000 times a mile, as the knee bends through 30 degrees. Exactly 30 degrees. That fibrous band is literally sawing back and forth across the bone. No wonder the bursa gets inflamed.
Exactly. It is a pure, repetitive friction injury driven by geometry. And because we understand the exact mechanical cause, we have a named physical diagnostic test that replicates it perfectly in the clinic.
I see the options here on the test bank. Is it the McMurray test for meniscus? The Lachman test for ACL? Apply-grind? Pivot shift?
Yeah.
Or the Noble compression test?
It is the Noble compression test.
Walk me through the mechanics of the Noble test step by step so the listener can visualize performing it in the exam room.
You have the patient lie supine on the table. You place your thumb directly over the lateral femoral epicondyle and apply firm, direct pressure inward. Then you take the patient's ankle with your other hand and passively move their knee through a full arc of flexion and extension.
So you are manually pinning the IT band against the bony prominence while moving the joint beneath it.
Exactly. You are artificially eliminating any slack in the system. If the patient reports a sudden, sharp, reproducible pain right at the exact moment the knee hits 30 degrees of flexion, the test is definitively positive. You have manually exacerbated that exact moment of maximal geometric friction.
Now, how do we treat it? If the problem is purely mechanical friction, I am assuming we just try to increase the clearance or reduce the number of cycles. So stretching the band.
Yes. The primary treatment is stretching the iliotibial band complex to add microscopic compliance, combined with an aggressive reduction in running mileage to immediately decrease the number of friction cycles, and prescribing anti-inflammatories to calm the local bursitis at the epicondyle. It is a conservative ladder, and it is highly effective for the vast majority of patients. Surgery, which generally involves making a small cut to release or lengthen the posterior fibers of the band directly over the epicondyle, is strictly reserved for highly refractory cases that fail months of dedicated rehab.
You know, this structure, this massive IT band, it feels completely familiar. Doesn't this connect directly back to the hip module we did a few weeks ago.
It absolutely does, and making that anatomical connection is how you elevate your knowledge from rote memorization to true surgical understanding. It is the exact same continuous anatomical structure causing mechanical problems at both ends of the femur. Down at the knee, it rubs against the lateral epicondyle, causing ITB friction syndrome. But up at the hip, that same tight fascial band rubs against the massive greater trochanter of the femur, causing what we call external coccyx sultans, or snapping hip syndrome. One single fibrous structure, two ends of the bone, two distinct friction syndromes governed by the exact same physics. And for both pathologies, the treatment ladder is identical. Stretch it, rest it, and only if that absolutely fails, surgically release it.
That is a brilliant synthesis. Give me the ITB one-liner.
Iliotibial band friction syndrome causes debilitating pain at the lateral femoral epicondyle precisely at 30 degrees of flexion, is confirmed clinically by a positive Noble compression test, and is treated initially by stretching and reducing running mileage.
Let's do recap 2. I'm going to fire these off rapidly to lock the Shin and D concepts in. Shin scans. MTSS is delayed phase only, non-focal, and located on the posteromedial tibial border. True stress fractures show early phase blood pool uptake too, and they are highly focal dots. MTSS is treated with activity modification, ICE, and NSAIDs. Releasing the soleus fascia is rarely indicated. For CECS, the manometer pressures are 15 at rest,
15.
30 at 1 minute post-exercise,
30.
and 20 at 2 minutes.
Exactly 20.
The differential includes tibial stress fractures, popliteal artery entrapment, MTSS, and nerve entrapments, but definitely not a femoral neck stress fracture. Activity modification works if they actually stop running. Otherwise, you have to do a surgical fasciotomy. And for the IT band, friction syndrome hurts at the lateral femoral epicondyle at exactly 30 degrees. Flexion? You confirm it with a positive Noble compression test. Treat with stretching and reduced mileage.
That is a flawless summary. We are now down to segment 5, the hamstring, the Achilles, and geometry. We have 3 final, highly mechanical concepts to cover to close out the entire lower limb series. Let's start with the posterior thigh, the chronic hamstring.
Okay, patient walks in with an old chronic proximal hamstring rupture. What is their most common functional complaint? I want to throw out some plausible wrong answers here. Is it severe weakness, like an inability to stand up from a chair? Is it severe night pain? Or difficulty climbing stairs?
It is actually none of those, and that is why this question tricks so many people. The most common complaint and the correct multiple choice answer is difficulty decelerating the leg. Difficulty decelerating the leg.
Decelerating, not pushing off. That requires us to do a deep dive into gait biomechanics. What are the hamstrings actually doing when we walk or sprint? I think the general public assumes they are just the primary engines that flex the knee backward.
They do flex the knee, but in the context of human running gait, that is a minor function. To understand why a ruptured proximal hamstring causes difficulty decelerating, you have to closely examine the terminal swing phase of running. When your leg is swinging forward through the air, your massive quadriceps muscles are firing forcefully to extend the knee. That lower leg, the tibia, is whipping forward like a heavy pendulum. Before your heel violently strikes the ground, something has to catch that flying pendulum and slow it down. Otherwise, your knee would snap backward into catastrophic hyperextension.
Ah, I see the physics now. The hamstrings are catching the flying leg.
Exactly. The hamstrings work eccentrically during this phase. Eccentric contraction means the muscle fibers are actively trying to shorten and generate force, but the gross muscle is physically lengthening under the tension. They are acting as the heavy brakes for your swinging tibia just before heel strike. They are the braking system, not the engine.
So if you rupture your proximal hamstring at the ischial tuberosity, you completely lose your braking system.
You lose your brakes, but you retain your forward power from the quads. That is why these patients do not typically come in complaining of weakness when standing up from a chair. They come in saying things like, when I try to run downhill or when I try to sprint at top speed, my lower leg literally feels like it is running away from me, out of control. They cannot physiologically slow the rapid forward swing of their tibia.
That makes perfect sense once you break down the pendulum physics. Let's move from the brakes of the thigh down to the ultimate engine of the foot, the Achilles tendon. There's a massive clinical trap here that ruins lives.
A massive trap, and one that leads to devastating, career-ending misdiagnoses in the emergency department every single day. Let's look at the Thompson test, also historically known as the Simmons test, which is used to diagnose an acute Achilles tendon rupture.
How does the mechanical test actually work?
You have the patient lie prone, flat on their stomach, with their feet hanging completely off the end of the examination bed. You then take your hand and physically squeeze the meaty belly of their calf muscle. If the thick Achilles tendon is intact, squeezing the muscle belly forcefully pulls on the tendon, and the foot will involuntarily point downward. That movement is plantar flexion. If the Achilles tendon is completely ruptured, that mechanical cable link is broken. You squeeze the calf muscle, it bulges, but the foot does absolutely nothing. It hangs there still.
So a positive clinical test for a rupture is the absolute absence of movement.
Yes. The total absence of movement when squeezing the calf is positive for a full rupture. But here's the trap, the reason this gets missed constantly by junior doctors. A patient with a complete, severe, totally severed Achilles rupture can often still actively plantar flex their ankle if you simply ask them to push their foot down, like stepping on a gas pedal.
Wait, I need you to explain that to me. If the main cable connecting the calf to the heel is completely severed in half, how does the foot actively move downward?
Because while the Achilles is by far the largest cable, it is not the only one crossing the ankle joint. You have intact secondary helper muscles, the flexor hallucis longus, the flexor digitorum longus, the tibialis posterior, and the peroneal muscles all cross the back of the ankle and all assist in plantar flexion. They are vastly weaker than the mighty Achilles, but without the heavy resistance of the patient's body weight when the foot is just dangling in the air, those helper muscles work perfectly fine to push the foot downward.
So a patient limps into the ER. The busy doctor says, point your toes down for me. The patient points their toes using all those tiny secondary helper muscles, and the doctor thinks, great, the Achilles must be completely intact.
Exactly. A patient who can actively wiggle their foot downwards has absolutely, positively not excluded a ruptured Achilles tendon. You must test the mechanical continuity of the tendon by squeezing the calf, not just test the active, unresisted movement of the joint.
Which brings us to the final concept of this deep dive, and essentially the master key to the whole module series, CORA. And I noticed what looks like a typo in the source material for this one, right?
Yes, the source text mistakenly writes COPA with a P in the question stem. The correct orthopedic term is CORA, C-O-R-A. It stands for Center of Rotation of Angulation. Center of Rotation of Angulation.
What does that actually mean mathematically, and why is it so important when you are planning a surgery?
Imagine a long bone, like a tibia, that has healed crooked after a terrible fracture. It has an angular deformity, a bend in the middle. If you draw a straight line down the anatomical or mechanical axis of the top half of the bone and you draw a second line up the axis of the bottom half of the bone, those two imaginary lines will intersect at one specific geometric point in space. That exact point of intersection is the CORA.
The center of rotation of angulation. Okay, so it's the exact geometric hinge point of the crookedness.
Exactly. And finding that point dictates the golden rule of osteotomy, which is when we have to surgically cut the bone in half to straighten the leg out. The geometric rule is this. If you surgically cut the bone exactly at the CORA, the bone will hinge open and correct its angle perfectly without creating any step-off or translation between the two ends.
What if you cut it somewhere else? Like, what if the CORA is way up near the knee joint, and it's surgically much easier for you to make the cut further down the shaft in the middle of the leg?
If you choose to cut anywhere else on the bone, you can still perfectly correct the angle, but you will mechanically induce a translational deformity. The two ends of the bone will slide sideways relative to each other. You fix the angle, but you create a massive step in the bone. Cut exactly at the CORA, no step. Cut away from the CORA, you correct the angle, but you create a step.
Correct the angle, create a step. It all comes down to pure unforgiving geometry.
It does, which leads perfectly into our scar story beat. Because ignoring these simple, unforgiving biomechanical rules leads to disastrous, life-altering, real-world outcomes for patients.
Give me the haunting clinical tale, the scar story.
This is the story of the missed Achilles because it is the most common and arguably the most tragic avoidable disaster in sports medicine. We have a 45-year-old man. He is playing badminton, the absolute classic weekend warrior scenario. He lunges forcefully backward for a drop shot and suddenly feels a massive concussive blow to the back of his ankle. He literally turns around, angry, convinced his doubles partner has hit him with a wooden racket.
But no one is there behind him. That's the classic textbook presentation of the snap.
Textbook. He hobbles off the court and decides to drive to the local emergency department. He is limping heavily, but he is fundamentally walking.
He literally walks into the ED on a severed tendon.
Walks in. He is eventually seen by a junior doctor who is 3 hours behind schedule and completely overwhelmed with trauma. The doctor hears the history of ankle pain while playing sports, takes a quick visual look at the swollen ankle, and asks the patient to point his toes down towards the floor. The patient complies. He points his toes down perfectly because, as we discussed, his flexor hallucis longus and his tibialis posterior are entirely intact and firing.
The helper muscles completely mask the catastrophe.
The helper muscles completely mask the void. The busy doctor sees the foot move, diagnoses a simple, benign calf strain, tells the patient to ice it, and sends him home without crutches, without a boot.
And nobody squeezed the calf to do a proper Thompson test.
Nobody squeezed the calf. Nobody took 1 single second to run a gloved finger down the back of the ankle to feel the massive, palpable 2-inch gap where the thickest tendon in the human body used to be. Fast forward exactly 6 weeks. The man returns to the orthopedic outpatient clinic. He is still limping terribly. He is completely unable to push off that foot to walk up a flight of stairs. And now the diagnosis is a chronic retracted Achilles rupture.
Retracted, meaning the severed ends of the tendon have pulled far apart like a snapped rubber band and scarred over during those 6 weeks.
6 weeks,
Yeah.
exactly. The massive calf muscle has contracted unopposed, pulling the top stump inches up into the leg. What could have been treated non-operatively in a simple cast on day 1 or with a tiny 30-minute end-to-end surgical repair is now a massive, horrific salvage operation. He needs a huge longitudinal incision, a tendon transfer cutting a tendon away from one of his toes to bridge the gap, and months of grueling, agonizing rehab with a permanently worse functional outcome. He will never play badminton again.
All because someone tested the active movement of the ankle instead of spending 8 seconds squeezing the calf muscle.
All because of a failure to understand the underlying mechanics of the foot. It takes 8 seconds to squeeze a calf. That is the entire diagnostic intervention.
That is deeply sobering. Give me the one-liner for segment 5.
A chronic hamstring rupture means difficulty decelerating the swinging leg. A completely ruptured Achilles can still actively plant R-flex, so you must always squeeze the calf, and corrective osteotomies must be performed at the geometric intersection lines, the CORA.
All right, it is time for the lightning round. I'm going to fire rapid, aggressive questions covering the exact stats, facts, and percentages from everything we've talked about today. You need to fire them back perfectly. Ready?
I'm ready.
Primary site of injury in athletic pubalgia.
The rectus abdominis insertion onto the pubis.
Mechanism of that injury.
Repetitive trunk hyperextension and thigh hyperabduction.
Commonest physical finding and the exact percentage.
Pain on resisted hip adduction.
80%.
Exactly 88%.
Is there a hernia?
No, by absolute definition.
Initial management for pubalgia.
Rest, followed by a core trunk stabilization program.
Surgical option if that conservative therapy fails.
Modified Bassini repair.
Outcome of adductor tenotomy.
Return to full sport at a mean of 14 weeks. 14 weeks, despite objectively decreased adduction strength.
Compression side femoral neck stress fracture. Under 50%.
Protected weight bearing and observation with a further metabolic workup.
Over 50%.
Percutaneous screw fixation, over 50% fix-it.
Tension site fracture on the neck.
Always surgical fixation.
The female athlete triad.
Disordered eating, amenorrhoea, low bone mineral density.
MTSS on a technetium bone scan.
Delayed phase only, non-focal, along the posteromedial tibial border.
True stress fracture on a bone scan.
Early phase as well as delayed and highly focal.
MTSS surgical treatment note.
Soleus fascia release along the posteromedial border is rarely indicated.
CECS resting fascial pressure.
Greater than or equal to 15 millimeters of mercury. 15.
1 minute post-exercise.
Greater than or equal to 30 millimeters of mercury.
30.
2 minutes post-exercise.
Greater than or equal to 20 millimeters of mercury. 20.
Which diagnosis is explicitly not in the CECS differential.
Femoral neck stress fracture.
Definitive treatment for CECS if the athlete absolutely won't stop.
Fasciotomy of the affected compartments.
ITB friction syndrome, where and at what exact angle?
Lateral femoral epicondyle at precisely 30 degrees of knee flexion. 30 degrees.
Which specific physical test for ITB?
The Noble compression test.
Chronic proximal hamstring rupture complaint.
Difficulty decelerating the leg during the swing phase.
Which finding is not consistent with an Achilles rupture?
Slanted flexion of the foot during the Thompson squeeze test.
Can a complete Achilles rupture still plantar flex actively in the air?
Yes. Using the flexor hallucis longus, flexor digitorum longus, tibialis posterior, and peroneals.
What does CORA stand for?
Center of rotation of angulation.
How is it defined geometrically? The exact intersection of the proximal and distal mechanical axis lines.
And why does the CORA matter for surgery?
It is the exact level at which a corrective osteotomy should be performed to avoid inducing a translational step deformity.
Perfect. Which brings us to the series outro. This is it. We have reached the finale of 9 extensive modules covering the entirety of lower limb pathology.
175 complex questions, ranging all the way from the piriformis muscle in the deep buttock down to the geometric cori in the tibia.
Can you compress this entire orthopedic series for the listener? If someone is listening to this in their car, about to walk into a massive, career-defining Viva examination, can you summarize the core of all 9 modules in exactly 9 sentences?
I can. One definitive sentence per module. Here we go.
Let's hear it.
1. The piriformis is the equator of the buttock, the superior gluteal nerve X above, the sciatic nerve below, and only the Smith-Peterson approach has a true inner nervous plane. 2. Osteonecrosis follows 40% of hip dislocations. Cam impingement presents as a pistol grip deformity. The false profile view shows anterior coverage, and you never, ever fuse a hip in abduction.
Got it.
3. Frictional torque follows the head-to-socket ratio, while the primary arc of motion follows the head-to-neck ratio. Lewinnick's safe zone for a cup is 40 degrees plus or minus 10 and 15 degrees plus or minus 10.
Okay, 4.
4. Anterior ACL tunnels will cost you knee extension, and vertical tunnels will cost you rotational stability, and a normal Lachman test absolutely does not mean you have a stable knee.
5.
5. A dial test that is positive at 30 degrees but normal at 90 degrees indicates an isolated posterolateral corner injury, and an unrecognized, untreated corner is the single commonest reason a good ACL reconstruction fails.
6.
6. The meniscus only heals where it has a direct blood supply, cartilage heals defectively as type 1 scar tissue, and von Willebrand disease is an autosomal, not an X-linked bleeding disorder.
Number 7.
7. The patella is actually damaged by the violent relocation event, not the dislocation itself, and the medial patellofemoral ligament, the MPFL, provides 50 to 60% of the restraining force from the second medial fascial layer.
Almost there. 8.
8. In total knees, the tibia cut affects both flexion and extension gaps equally. The distal femur cut affects only extension. The posterior femoral cut affects only flexion. And everything else in knee balancing is just applying those 3 rules in a different order.
In the final sentence. 9.
9. In a young athlete presenting with a normal radiograph, the true diagnosis hides in the compartment pressures, the specific bone scan phase, and the biomechanical question you didn't think to ask.
That is the entire series. That is incredible.
That is the series. But before we finish today, I want to reflect on the overarching philosophical theme that binds all of this together, because it is worth saying out loud to the listener.
Please go ahead.
Think about everything we have covered across these 9 modules. Almost nothing was just a random medical fact you couldn't look up in a textbook if you had to. What made the critical difference between a successful outcome and a surgical disaster every single time was geometry.
Always geometry.
It is always about geometry. It is about where a biological structure sits in 3-dimensional space and what catastrophic things happen when you put something just a few millimeters away from where nature intended it to be.
Right.
You split the gluteus maximus exactly 5 centimeters above the greater trochanter to avoid destroying the nerve. You place the tibial tunnel exactly 10 to 15 millimeters below the joint line. The lateral collateral ligament sits exactly 0.9 centimeters from the posterolateral tibia. The patella doesn't fully engage the trochlear groove until exactly 15 degrees of flexion. Geometry decides the outcome. Success or failure in this field is decided entirely by millimeters and degrees.
Millimeters and degrees.
Millimeters and degrees. Learn the exact millimeters and degrees, and all the rest of orthopedics is just commentary.
Which leaves us with one final provocative thought. Building on this idea of geometry, think about how our entire evolutionary history is essentially a compromise of structural architecture.
Yeah, that's very true.
We transitioned from walking on 4 legs to walking on 2 bipedal legs, which freed our hands but forced our pelvis, our hips, and our shins to carry loads in ways the original mammalian blueprint never intended. Nature prioritized forward bipedal movement over structural longevity. We live in this modern era of incredibly high-tech biologics, stem cells, PRP injections, robotic-assisted surgery, and artificial intelligence.
Right, all the flashy tools.
But all of that technology is ultimately just trying to patch up the fragile, compromised architecture of bipedalism. You can have all the advanced biologics in the world, but if you don't respect the sheer mechanical limits of a femoral neck under tension or the fluid dynamics inside a rigid fascial compartment, biology will fail. The physics always wins.
Physics always wins.
Thank you so much for guiding us through this entire journey. It has been a masterclass in biomechanics.
You're very welcome. To the listener out there, you know the numbers, you know the angles. Now go and pass it.